It's my pleasure.
All right, so I'd like to welcome Mr. David Shahnazaryan to our PCC rounds. And we're very appreciative of David's time. He's joining us from the UK. It's 10 p.m. at night, so thank you so much for taking the time out of your schedule. I know you must have had a long day to join us with this. Now we're really lucky to have David because he's got quite an interesting background. From Armenia, he did a residency in plastic and reconstructive surgery. And then because he had extra time on his hands, he did an ophthalmology residency in Ireland. And because he had a bit more extra time, he did a corneal anterior segment fellowship and then an oculoplastics fellowship. And so he's super well trained. And we're very happy to have you join us. And right now, David is working at King's College Hospital, NHS public system, as well as Center for Sight. And so today's topic is post-keratoplasty astigmatism correction. I think many of the cornea people and even general ophthalmologists or cataract surgeons have to deal with. And so without further delay, David, I'd like to hear your thoughts on this very interesting topic.
Thank you very much for inviting me. It's a privilege to be talking. I follow your cornea rounds regularly and always have great topics, so I'm happy to contribute. So, as you said, I'll be talking about the correction of post-keratoplasty astigmatism, and we're really talking about, when we try to describe astigmatism to the patients, I usually compare the football to rugby ball shape. Thankfully, I'm not in North America, where I'm sure that would have confused many. So probably it's safer to talk about basketball and rugby ball. So, but in essence, it's all about the shape, really. And the choice of treatment really depends on the shape and the cause, which is the main topic of my talk. So keratoplasty, mostly it's, we are talking about the deep anterior lamellar keratoplasty or penetrating keratoplasty when it comes to astigmatism, and it is well known to be associated with irregular shape postoperatively. Can be regular or irregular, which can be a challenge to correct. There are many reports with regards to the outcomes, and it's been reported that up to 40% of keratoplasties have an average of 5 diopter of astigmatism, and up to somewhere between 8 to 20 require additional surgery to correct this. There are many factors that influence the development of irregular shape, the suturing of the graft, the centration of the graft. Everyone heals differently. The postoperative fibrosis will also influence the amount of irregularity. The presence of ectasia in the host. Have you removed the whole of the unhealthy cornea, and also the mismatch between the donor and the host and wound slippage. So it's all about the assessment, really, and it starts from simple slit lamp examination. You want to identify all the abnormalities, the thinning. Is there any sign of residual keratoconus in the host cornea? Do the sutures look tight? How is the wound healing? Of course, refraction is also important, both to identify the visual potential, how much is this limiting the patient, and stability, is it still progressing? Do the patient tolerate contact lenses? These days there are so many additional diagnostic tools available in our arsenal. Topography, tomography, of course, is a must diagnostic tool, and it helps us to identify whether it's regular or irregular. And I'll talk about the use of this method when I discuss specific treatment options. And once you've examined the cornea, the slit lamp, and you have identified area of thinning, then you want to know what's causing this. Anterior segment OCT is a great tool just to see the location of the problem. For example, in this image, it's clear that the thinning is not in the graft. We get referrals. This patient was referred by the optician, was saying that the keratoconus has recurred in the graft, and you need to have all these tests available to decide the treatment options, because this will greatly influence it. Now, in terms of the treatment options, a small amount of astigmatism, usually less than 4 diopter, can be corrected with spectacles or soft contact lenses. More significant amount of astigmatism responds usually to rigid gauze permeable contact lenses, but we know not everyone is tolerant. Many issues associated with the irregular shape and recurrent infections. Patients who are intolerant to contact lens correction, or indeed they don't get the best visual acuity, they need further treatment, and that means surgical correction. So what are the treatment options? And so I'll be talking about these treatment options, and I haven't included the use of intrastromal corneal ring segments. And to me personally, this is less reliable option even in keratoconic patients, so even less so in corneal transplantation. So this prevention is better than cure. This saying was attributed to Dutch philosopher Erasmus, and of course it's applicable in all aspects of medicine. And here, when we're talking about the astigmatism, it starts with your technique, how you prepare the graft, well-centered, the good suturing techniques. Initial report, they've discussed a lot about the possibility, the influence of the suturing technique on the induction of astigmatism. And there are many studies on previous talking about if it's a running suture, which helps you to adjust the direction of the toric or not toric. Later, however, with more experience, we realized that everyone heals differently. You use the method that you are comfortable with. In fact, probably the most reliable has been shown by Tom Holland that it's the multiple interrupted suture, because you really want good opposition of the corneal graft with the host tissue. Simple tools that you can implement during the surgery itself and try to assess the irregularity of your corneal graft. Intraoperative keratometry, described by Trautmann back in 1993. Now, it's a tricky device to use, and there's only a certain amount of astigmatism that you can perceive with your eye, and also depending how close you hold the keratometer to the cornea. If you tilt it, it can greatly change the reflection of the cornea. So I don't know, I don't use this as much. And Morlet introduced the astigmatic ruler, which to some degree eliminates this issue, because you orient the inner circle of these rings with the corneal limbus, and then avoid the issue of the distance. And I use this ruler, and it works for me, but everyone probably have their own ways of ensuring the best opposition and of the corneal graft. Now, the selective suture removal has been described by Binder in 1985. There are many, many reports, of course. And the idea is checking if any of the sutures are causing significant astigmatism, and you remove a suture along the steep axis. Back in those days, it was used by keratoscope. As you can see from the image, there's a tight suture there. and then the cornea looks more regular after the removal of the suture. And another group as reported by Faras and Dua, and they've done a study that assessed the stability of topography. So they've removed the suture, did a topography 30-40 minutes later, and then compared the topography 4 weeks to 6 weeks later, and it was unchanged. So the suggestion is that you can repeat the topography 30-40 minutes and continue same-day suture removal instead of bringing the patients back. Astigmatic keratotomy is such a simple tool, but very useful. It can be done with manual or femtosecond assisted. It can be augmented with sutures. There are multiple nomograms. As a rule of thumb, 1 clock hour can correct up to 2 dots of astigmatism. You have to treat the graft host interfaces in your limbus. Usually the incisions are done either at the junction or inside the graft. And you can do it at the slit lamp. You better have steady hands, of course. And as you can see, it's done, instead of creating a new wound, you do it at the interface. And you can do it with a guarded knife, of course. Under topical anesthesia. And this treatment can be repeated. And of course, you do it along the steep axis. So this is a paper, again, about in-office relaxing incision for the correction of astigmatism. So they found that there is about 3 diopter of astigmatic reduction. As Googling AK knife for the photo, this is what I found. So, so yeah, just don't do that. And another article came from Canada, team in Canada, which compared the results of manual with femtosecond assisted astigmatic keratotomy. What they've shown that both methods are effective. The femto-assisted has better astigmatic outcome and visual correction. Most likely this is because, as you can see, there's deeper incision done with femto laser. I guess that's for the safety issues. However, this results in high rate of overcorrection, but both methods are safe and effective. Now, another method is intrastromal AK. As you can see in the video, and it's possible with the help of the intraoperative anterior segment OCT. It's a great tool. You can adjust the exact height and the location, and you don't disrupt the epithelium. And you'll see in a moment, there 10% depth and up to 85% the inner depth. Very safe, very controlled. This patient had very little change during the initial first stage, but then at the next follow-up, 6 weeks later, he had more than 6 diopter of astigmatism fully corrected. And you don't have to disrupt the epithelium, you just leave it. So again, we're talking about the shape. So, which is why it's extremely important to identify where the problem lies. Patients who have ectatic cornea at the interface or thinning, you cannot do arcuate keratotomy there because that's not where the pathology is. It will be highly unpredictable. Wedge resection was described by Troutman in 1973. He, however, described the removal of a wedge tissue from the corneal graft. Of course, going back to the initial part of the talk where you need to assess, you need a full examination, anterior segment OCT. As you can see from this image, the problem is not in the graft. Removing the wedge in the graft won't do any good. And so you have to remove the abnormal cornea. There are different nomograms available, and about 0.1 millimeter corrects one diopter of astigmatism. Most of these patients have a very high degree of astigmatism, up to 10 diopter. So often you remove 1 millimeter of wedge. It can be done manually, and you do it along the steep hemimeridian, and then you suture the and by stiffening the flat meridian, you cause compensatory flattening of the stiffening. It's called coupling effect. And you get twice as much stiffening as you get flattening, which can cause myopic shift. So this was a study done by Shahnazaryan's team, 3 cases, and they again, it just shows that all of those patients who required wedge resection, they were patients with either small graft and which missed the keratoconus, and in the host that led to recurrence of and progression of keratoconus in the host cornea over the years. They all did well. And so this is the manual technique. You use your blade just to cut the wedge. Can be challenging, and you angle it towards the corneal graft, the outer section, and then you suture it with interrupted sutures. You can initially use a combination of nylon and merceline. Nylon is not as resilient, it tends to stretch, so often you lose some of the correction. So in most of these cases, you want to overcorrect about 50 to 100%. And merceline now is the choice of the suture material because it's more stable. So all of these patients had significant reduction in their astigmatism cylinder. And with the advent of femtosecond laser, there are other techniques described. You can use the femtosecond. And here, Dimitri Azar demonstrated this simple formula, geometric formula, how to create the wedge, because the femtosecond machine doesn't have an option of just cutting a wedge. So they use 2 concentric rings, one bigger than the other. And the amount of displacement can be calculated from this formula, for example, 1 millimeter. Just this way. And then I'll show you on the video. This was done on pig eyes. And you shield the rest of the cornea by just touching a tape. And you can see the first cut is done. Then the second one. Of course, even more simple option will be to do 2 parallel arcuate keratotomies, and then just remove the wedge. Now, how about, this is a great option, the wedge resection, if the ectasia, the abnormal shape, is limited. How about those cases where it's more extensive? And in some cases, it involves more than just 90-degree. And DALK over PK is a great technique that can enhance the corneal graft, because you have to take into account that those patients who have bulging graft, very irregular surface, but they still have a clear graft. The graft itself has survived in many cases for many, many years. So there is the immune privilege. You want to preserve the tissue, but you need to get rid of that high degree of astigmatism. So this is a technique that's been shared by Shahnazaryan. So you start dissecting from outside the graft. Obviously, you need to examine very carefully to identify any thin areas. And this is how it looks post-operatively at the slit lamp. You can see much larger graft, and you can see the smaller graft within the DALK. And the patient has very good outcome. So what are the other options in patients who just have astigmatism due to irregular wound fibrosis, where the rest of the cornea is stable, and thanks to laser correction options, you can these days treat this type of astigmatism. The options are photorefractive keratectomy. However, this option method has a number of disadvantages. You're treating the surface, so often it's associated with epithelial defects. You are inducing inflammation, which is not great for the graft. You are increasing the risk of rejection. The amount of correction is also limited, and also the worst of all, it is known to be associated with post-treatment corneal haze. Some authors use mitomycin C to reduce the risk of post-treatment corneal scarring. However, it's a horrible drug. A number of studies have shown that you can detect mitomycin C in the anterior chamber after the treatment, and it's a horrible drug. It has toxicity. It can affect the endothelium. It's best to be avoided. And LASIK, on the other hand, has a number of advantages. It induces minimal inflammation. There's a much bigger range of correction that you can do. You can retreat the patient, and you can combine with other treatments. Previously, it was combined with AK after the flap. It does require very careful selection. You have to make sure the patient has a healthy ocular surface, and there was no recent graft rejection and no active rheumatological disease. Now, how about patients with a significant high amount of myopic astigmatism? Again, it's all about the shape. You really need to assess these patients carefully. As you can see from this topography map, there's a bulging of the cornea here on both sides. If you try to do simple astigmatic correction, you will remove a lot of the tissue from the central graft, but you won't get the good result because you left these areas outside. A better approach has been offered by Shahnazaryan, where you split the cylinder. So what you do, you correct 3 diopter of negative astigmatism, myopic astigmatism along this axis, and then you treat +3 cylinder on both sides. Therefore, you reshade the cornea. You have achieved much more regular surface. Here it's Bitoric ablation. This patient, again, with similar principle, you can see there's a significant amount of astigmatism, 3 and 9 o'clock, and much better ocular surface after the treatment. Now, previously, when the LASIK was done with microkeratome, this has been associated with number of flap complications, such as flip flap, partial flap, buttonhole, and other risks well known for microkeratome LASIK, such as epithelial ingrowth. And you have to be careful also when you're creating your LASIK flap, try to keep it within the graft, because going through the graft host interface can weaken the graft. Now, femtol LASIK helps to avoid many of these issues. Here you can see the creation of the flap. It is a delicate treatment, and you have to make sure that there's no thin areas in the graft. And you do intraoperative phakimetry to make sure the corneal thickness. And there you go. This patient can have very good result following careful selection. Another option for correction of astigmatism is the use of phakic toric IOLs, either toric implantable collamer lens or artisan. And it's good candidates for this kind of treatment will be younger patients. And the advantage of the treatment is that it's reversible and has a good safety profile. It's been available for many years. There are a significant amount of published data. And they do require stable keratometry and good refraction, because the calculation of the IOL power heavily relies on your refraction. These patients do require regular follow-up. You want to measure the volt of the lens. You want to assess the endothelial cell count and check the pressure and ensure the stability. There isn't, interestingly, that many published data available. This article from China has shown the use of implantable toric collamer lens in 9 patients with DALK. Again, they've used the same selection criteria: sufficient AC depth and healthy endothelial cell count, and of course, absence of cataract. And they've got good results. So to conclude my talk, treat the patient, not the numbers, and very careful preoperative assessment is important. It all comes down to the basics. You want to know the cause and the shape, which will determine the choice of treatment. If the patient has host ectasia, unstable interface, then you have to get rid of it. You have to correct that. There's no point going for arcuate keratotomies. In this case, you have to remove unhealthy stroma. So wedge resection or DALK over PK is a great option. In a moderate amount of astigmatism, manual or femto AK could work well. In the other patients with stable graft host interface, laser refractive surgery provides great tools such as LASIK, preferable to PRK due to associated post-treatment scarring. Thank you very much. I'd like to thank Center for Sight for providing much of the material for my talk, and of course Precision Corneal Center for giving me this opportunity to present this topic.
Great, thank you so much, David. That was great. I'll leave a few minutes perhaps for some people to think of questions to ask you, but I had a question, I have a few questions actually. For your wedge resections, you're mentioning 0.1 millimeter per diopter, and then aiming for 100% more. So would that mean if you wanted to, say, tackle 3 diopters, you would do 0.3 or 0.6?
No, that's based on the final result.
Okay.
So, yeah.
And then how deep is your, on the peripheral side of the cornea, on the host side?
Yeah, you aim at least 90% depth. Okay. Yeah, 90%.
All right. And the other question I had is, with your femto LASIK post PK, when you are dissecting that flap off that stroma, is there any issues with the graft host junction?
Yes, that's why, of course, as I said during the talk, you try, if possible. It was a bigger issue before when you were doing with microkeratome, and with femtosecond, and you know, with your experience, you just go by the field. Preoperatively, of course, you assess the graft interface to see the amount of healing. Once the laser has gone through the interface, then it's relatively easier to lift the flap. However, try to keep the flap within the graft.
Right.
That's because, not just because of the challenges of lifting the flap. Lifting the flap is relatively straightforward, but we have reviewed some of the data from previous femto LASIK over PK going back 10 years and more, and then we found that cutting through the interface potentially weakens the graft, so some of them tend to progress afterwards. Okay. The shape, there's increased amount of astigmatism. It reduces the stability.
Okay.
So and, try to keep the flap within the graft.
Within the graft, okay. And then for your LASIK here, how much correction can you get typically, and what kind of laser platform are you using?
Yeah. So the amount of correction, again, as you can see, I mean, we can correct somewhere between 6 to 8 diopter, and it really depends on the thickness of the graft as well, and depends on the amount of astigmatism. Some patients you end up doing retreatment. Previously, we did also arcades under the flap. We don't do that anymore because with the modern platforms, we get the sufficient amount of treatment. And so, yeah, so what was the next question?
The laser platform?
And
what kind of laser do you use for that?
Intralaser.
Intralaser, okay. And then for the excimer ablation?
Excimer, Johnson & Johnson.
Okay.
Yeah.
The visit. Okay, I see.
Yeah.
Yeah. Hi, David.
Hi.
Yeah. For the wedge resection that you described, what is the normal suture material that you use, and how much longer do you keep the sutures on before removing them?
So I use Mercilin because it's more stable, and there have been a number of publications with regards to when to remove the suture. Some they advise starting around 2 months after the surgery, and I'm a bit conservative in terms of removal of the suture. It all depends on how regular it is. You can start removing them 6 to 8 weeks and up to 6 months after the treatment. Yeah.
Yeah, and in terms of astigmatic keratotomies, we do know that when it is done along with cataract surgeries, there is quite a bit of regression that happens over a period of the next 6 months to 1 year. But in terms of post-PK for correction of astigmatism, when we do either manual or femto astigmatic keratotomy, how much do you think is the regression that happens over the next 6 months or 1 year?
Yeah, you're right. There is some regression. It's not very predictable. It's like, again, depends on many factors and where you place the keratotomies, intraocular pressure, and the healing. And yeah, there is certain amount of, I don't think it's different.
Okay. And so it seems like you really don't like mitomycin C.
Yeah, that's true. I mean, as I said, there have been many studies on animal studies that they've shown presence of mitomycin C within the actives. And I mean, especially in cells that have high mitotic activity. And it also showed the toxicity for endothelial cells, for ciliary body. To me, it's a horrible drug. In fact, if there's someone pregnant among your staff, they shouldn't even be in the theater if you are using the drug for any other procedure. And also the association with the haze. I know there are some studies that they've used different concentration, and some reports showed that there's more haze with lower concentration, so the advice is to use higher 0.2%. But what's your experience?
I've been using mitomycin C. We use it in a few contexts. We use it in our excimer ablations that are above a certain amount of myopia, cylinder above a certain level as well. For about I've been doing this for maybe about a decade or so, and we're also using it for non-refractive things. For example, removal of Salzmann's nodules and putting a little bit of mitomycin C. Usually the concentration, depending on where I've worked, has been between 0.03, 0.04-ish. And the exposure has been usually 30 seconds or less. I know some of the participants here, if they want to raise their hand, they can perhaps mention what their experience has been. There's some people in attendance who've used mitomycin at longer exposure levels, but that's been my experience. And so far, excuse me, knock on wood, it's been pretty okay. We've been able to minimize haze. So I know it's always interesting to see how people are with this particular medication. I know some people swear by it and some people who are very much against it. So
yeah, I guess I'm on.
Interesting to discuss this and kind of because does anybody have any comments from the audience in terms of their use of mitomycin?
Hi, it's Daryl Lewis here. I don't know if you can hear me, but
I can hear you.
The time that I use the most mitomycin is actually when I do a TCAT treatment for a topography guided treatment for keratoconus, and at the same time then go to sequentially same day do a cross linking. And in those patients, you get a very pronounced intense reticular haze that can last for up to a year. And if you don't use high doses of mitomycin C, then that can be very visually limiting. So in a lot of those patients, or say in a POE patient, I might use 0.02% for upwards of 2 minutes. I haven't noticed any real ill effects of using mitomycin C for that long. But I can tell you definitely the times that I've used it for less than 2 minutes or so, I've had significant problems.
And I guess a key question about safety is both David and maybe Daryl is how are you administering the mitomycin C? What are you doing to protect it from going on to the conjunctiva, hitting the lids, and other parts of the surface?
Well, I mean, I've been using a cornea light shield, the Miracell sponge, sort of the white disc that I think many of us have used as a corneal light shield, and then soak that in the mitomycin C and keep it sort of semi-wet so that the sponginess of the material wants to pull the mitomycin C centrally. So the only time you really have to be concerned about the mitomycin C, so rolling off and onto the limbus or onto the conjunctiva is really when you lift it off the surface, because you'll often see a tiny bit of pooling. So I'm just very careful as I lift it off to try to make sure that little bit of pooling that happens stays very central on top of the cornea, and then I quickly flush it off with copious amount of BSS afterwards.
My concern would be with the absorption. As I said, it can be detected in a very small amount, of course, and the issue with mitomycin that the effect can become prominent many years after the initial treatment. But of course, as you said, there are different approaches. And do you do endothelial cell count? Do you check?
I can honestly say no. I've never done endothelial cell counts before and after, and I definitely hear your concern, and I echo it. I think that I once looked at this for PRK and trying to look at studies that have done endothelial cell densities pre and post PRK with just 20 to 30 seconds at 0.02%. And there's actually no real good data out there. I was actually thinking this would be a very good meta-analysis to do to try and figure out, what is the actual endothelial cell density changes due to the mitomycin C. I guess it's a balance of evils, and maybe the topography guided treatment is avoiding a transplant in somebody for a period of time, in a POE patient or a keratoconus patient. So I think on the balance of evils, I think it's still on the better side, but I hear you when you say ciliary body toxicity, that's a different animal. Yeah,
that's one of the big concerns, because that's where you have higher turnout. But
yeah, well, that's, it gives us actually a great idea for me to ask our fellows to do a presentation on a point counterpoint on, one side takes I love mitomycin and the other side takes the side of I hate mitomycin, and then we can look at the literature and see what it shows, because I think these are all very pertinent questions that we ask ourselves every day. Good.
I agree.
Yeah, I'd love to have
any questions from the audience. Any hands up or anything like that we have? All right. Well, David, thank you so much for your time. It's been really interesting. We will have your talk up on our YouTube channel in maybe 20, 30 minutes, whatever it takes to get everything ready. But I do thank you for your time. I hope you're, for those that don't know, his building is in the process of being burnt down, I think, or are you still okay? Is that fire alarm okay?
My feet are burning, but that's okay. I survived.
Okay. Well, thanks for, despite the peril of smoke and fire, thanks for sticking through with this presentation, and have a great evening. And I look forward to meeting you in person, hopefully soon, when we get to going to conferences again.
Well, thank you very much for having me. It's been an absolute pleasure. And I also look forward to going back to normality, and I'd love to meet either Canada or any of the big meetings. Thank you.
Awesome. Okay, bye-bye, David.